you as referrers, and both in this session and also ongoing afterwards. And we'll do that in turn between myself, Bean, and Sarah and Johnny. So thank you very much. As Sarah said, I'm one of the directors of Momentum Newcastle, and we're the provider of the service in Birmingham and Solihull. So this is what we will cover over the course of the next hour or so. And please do add any questions you have into the chat, and any of us who aren't talking will try to respond to those, or we'll pick them up at the end if we don't get to them. So a little bit about the background, the research underlying the program and the benefits of it. So the studies that it's based on are the DIRECT study and Droplet, which many of you may have heard of, particularly DIRECT. And DIRECT was kind of the first study in this area that showed that remission of type 2 diabetes was possible at scale through a lifestyle intervention delivered through primary care. And in the DIRECT study, at 12 months, of the intervention group, 24%, so almost a quarter, had lost 15 kilograms or more, which was very significant for a lifestyle-based program, even one with 3 months of total diet replacement at the beginning. And almost half, or so just under half, 46%, had achieved remission, and the majority of those at 24 months. And the intervention group had fewer adverse events in it than the control group. Remission, as you'll not be surprised to know, is very closely linked to weight loss, just a sort of direct correlation. And remission in this circumstance for DIRECT and also for this service is defined by NHS England as having an HbA1c of less than 48 millimoles per mole for more than 6 months on no diabetes medications. Now, that means that some people who can still be referred to this service won't be able to achieve remission over the duration of the service, but might be able to later. But even if they don't, they can still get many of the health benefits that accrue from the service. Some of which include not just the significant weight loss that is likely if people follow the program, but also the possibility of remission from their type 2 diabetes, a reduction in their medications, so very significant for diabetes-related medications, but also blood pressure medications and potentially others. There's generally a positive impact on comorbidities, not everyone's comorbidities, obviously, but on quite a few weight-related comorbidities in particular, and an improvement in healthy living quality of life. The entire program, so all the support over 12 months and the total diet replacement products are all free. And there's a range of different case studies on that link. And by the way, I should have said, we will be circulating the slides, making the recording available after the session. In terms of benefits to practices, it's obviously, there's no cost to the practices because it's commissioned by NHS England through a national framework we'll get onto in a minute. The referrals are all eligible for the weight management enhanced service fee, so we'll pass it on. And yes, Erin, we'll send you the slides afterwards. And in terms of various different anecdotal benefits from for practices, but they're not actually able to quantify those, are reduction in usage, particularly because of for participants who are successful because of weight loss, the impact on comorbidities, and also the peer support they benefit from over the program. Okay, so the NHS England have taken an approach where first they piloted the service as a NHS low-calorie diet, which many of you may have heard of because Birmingham and Solihull were one of the first pilot areas. And then that progressed to 20 ICBs. And the pilot showed similar emerging results to the DIRECT study. And so as a result of that, NHS England commissioned a national framework. They also changed the name from the low-calorie diet to the NHS Type 2 Diabetes Path to Remission Programme, named T2DR, which sounds very Star Wars, but came out of various different patient focus groups hosted by Diabetes UK. And the design both of the pilot and the framework is very similar to DIRECT, and it's jointly commissioned with the ICB. In terms of us, you may or may not have heard of Momenta. We've been providing the service initially as the low-calorie diet and now as the T2DR program since the origin of the pilot in 2020. It used under the pilot, it was a virtual group, but now, well, delivery was two virtual groups, I should have said. But now with the advent of the framework, all of the areas it's turned into a one-to-one service, and all of the areas provide patients with their choice of either digital pathway or in-person pathway at clinics, and both of those are supported by trained coaches. The early outcomes were in line with the direct study and NHS England pilot of about 11 to 13% weight loss, depending on which contract and demographic. And it also seems to have a positive impact on health inequalities. So we've had a very disproportionate set of referrals in Birmingham and Solihull from the lowest two IMD quintiles, and also from particularly South Asian populations. But yeah, so thank you for all your referrals to date, if you've made them or your practice has made them. It's obviously helped both the pilot get off the ground and progress to a framework, and hopefully help your patients as well. In terms of what the program itself is, as we said, it follows the principles of direct. It's delivered by trained coaches. There are 3 phases over the 12 months. The first phase is 12 weeks, so 3 months worth of total diet replacement products. So that's where patients or your patients are participants, replace all of their real food with 800 to 900 calories a day of TDR products. Then the second phase takes 6 weeks, and that's where they gradually reintroduce real food. So kind of weaning themselves off the TDR products with introducing one main meal every 2 weeks. And then the final 7.5 months are up to 12 months are basically is the weight maintenance phase. And that's where there's much more of a focus on kind of healthy eating and increasing physical activities, the kind of content you'd see in maybe a diabetes prevention program or tier 2 weight management program, but it comes after people have lost a significant amount of weight, which is obviously different from positioning in those normal programs. There's also the opportunity to engage in a reset package or rescue package if people gain more than 2 kilograms over that weight maintenance phase. Touched on the delivery format already, and our supplier of the TDR products is now Habitual. So they have, we'll come on to what they have in a second on the next slide. And we also use Habitual, their app platform for the digital service. So we use still Momenta content, Momenta coaches, but the actual technology is provided by Habitual. In terms of the eligibility criteria, I won't go through these in huge detail because you'll get the slides afterwards. And there's also on your referral forms as a repeat, and in the NHS England guidance that is available online. There are a few just to highlight, because sometimes we get people referred to us who aren't eligible, and the main reasons that we get ineligible referrals are either because you send us referrals who are too old, so there's an upper age limit of 65, or there's also people must have been diagnosed with type 2 diabetes within the last 6 years. And unfortunately, NHS England are very clear on this. So actually, in the pilot, there was a little bit of leeway, but now 6 years and a day is still too late. So they're very strict on the cutoffs. It's from the date of you send us the referral, so it's not when they start the program, but it's 6 years prior to the date we receive the referral. In addition, there are HbA1c limits. So if people are on diabetes medications, it has to be 43 or above. If they're not on diabetes medications, it's 48 or above. And there's an upper limit of 87 in all circumstances. There's a long list of exclusion criteria, including being on insulin. Most of the rest in fact, and that one you'd probably expect as healthcare professionals. But there's also a kind of more subjective assessment. So if you think that it's not safe, your patients won't be able to monitor their medication changes safely or medication adjustments safely. That could be for a range of different reasons, including sometimes that some of the medications are prescribed not by yourselves but by secondary care, or are more sensitive. Then you should err on the side of safety and not refer them. But I will let Nabeen talk about the meds adjustments in more detail. Briefly about the program, I won't go through these sessions in great detail, but you can see that in this first phase of the total diet replacement, the sessions are more frequent. So it starts off weekly, which is important from a safety monitoring point of view, and then goes fortnightly and continues fortnightly through this second phase 2, and then becomes monthly in phase 3. You can see that in the first phase, we focus more on some of the behavior change and psychological aspects, because you don't want to be talking about increasing physical activity or healthy eating when people are on soups and shakes and a low-calorie diet. We also provide a range of different resources at different stages throughout the program. So we think your patients will be well looked after from a resource perspective, and obviously the digital app, or the app for those on a digital pathway. I mentioned we use Habitual as our TDR supplier, TDR product supplier. We used to use a different organization, some of you might have heard of, called Exante, but unfortunately they're no longer supplying, well, they're no longer supplying any TDR products, or existing shortly. And so we changed to Habitual. Habitual are a relative new kid on the block, but designed their product specifically to help patients achieve remission, as opposed to being a more generic meal replacement supplier. So they've got the broadest range, and they're used by about probably half the participants on this service nationally. They've got 2 porridges, 5 shakes and 3 soups. They're all vegetarian, and 4 of them are vegan. The participants order directly from the Habitual website. We provide them with voucher codes at the right time and advice about how to do it, obviously, and support. And obviously this is all at no cost. Just to give you an idea of some of the resources, we provide them with booklets on how to use their TDR products, workbooks, logbooks, trackers, online recipe books, access to an XE app for 12 months, which is a physical activity app, pedometers, wallet guards, etc. And this is some snapshots from the app. So nothing you probably wouldn't expect, but just so you can see some of the kinds of screens. So it's basically a very light interface. It's quite user friendly. It's got some fun gamification aspects around the rewards, etc. Right, so that was the service. Now, in terms of our relative roles and responsibilities, so that's primarily yours as referrers and ours as providers. So without you, there is no service, because there are no people referred to it. So the first step in any patient's journey onto the program is obviously from yourselves. We'll come to a few ways which you can identify eligible patients, but fundamentally it ends up with you filling out the referral and medication adjustment form and then sending that to us. We, and working together with the ICB, have produced a range of tools to support you in those different aspects. So whether that's patient information leaflets, landing pages, practice poster animation, etc. And Johnny will also, and John Lestery will support with drop-ins. We'll come to events if you want us to talk to your practice or a PCN level or a group of practitioners, then we'll talk about the service, how to refer, etc. Once you've sent us the referral form, we'll check it that they're eligible and the referral form is complete. If it's not, we will get back to you and request the missing information. But from the point at which it's complete and eligible, we will then contact the participant within 5 days, and our internal target is within 2 days, to tell them we've received the referral and offer them the opportunity to book a call with us at a point that's convenient for them. If they don't do that after a couple of prompts, then we will call them directly. But we find it's much better to allow them to select a time that they'd like to be called, as opposed to us just randomly calling them. We'll check their eligibility, we'll register them, and things, as well as an individual assessment. At that point, they will make a choice as to whether they want to do the digital version or the in-person version of the program, and we'll book them on accordingly, either help them download the app or book them onto a clinic that is coming up. Or if there isn't a convenient clinic, then we'll put them on a waiting list for when there is a convenient clinic. So on the program, we'll then deliver the 3 phases. That involves the standard delivery of the programs, as you can imagine, but also, importantly on this service, the monitoring. So we monitor not just attendance, but blood glucose, blood pressure for those on blood pressure meds at referral, and side effects or adverse events. If those measurements, so particularly blood glucose and blood pressure, outside certain thresholds, which Mubin will cover off, then we'll contact you and suggest or let you know that, and then also suggest a medications review, depending on what the threshold breach is and its severity. We don't bother you unnecessarily, so we work through the thresholds that are set out by NHS England, but we also have a GP medical director who reviews each case before we contact you. And she's very experienced in this service, having been doing it from the outset, but also she's a very experienced GP and very lifestyle interventions, lifestyle medicine. So we also report to both NHS England and the ICB, and we will communicate to you at certain points in the programme, as well as any threshold breaches. The majority of patients will not breach thresholds, so I talked about that, but that was more for your understanding of the safety monitoring, rather than to focus you on thinking you're going to get a deluge of correspondence from us about threshold monitoring. Ian will explain how the medication adjustments are more conservative than they were indirect, and so as a result, fewer people breach the thresholds than would have done otherwise. So that's what we do, and when we discharge people, either because they finish or they drop out, we'll also signpost them to other services. Over the course of the 12 months, there are 2 things for you to do. The first is a repeat HbA1c at 6 and 12 months. That's part of the specification from NHS England. We will write to you and let you know about that, so you don't have to diarise it, and we'll also remind the patient to remind you as well. And then if someone exceeds a threshold, then it will also be helpful if you can do, or necessary to do, a medication adjustment review. There's in a chat, there's a message about how we can help the patient with medication adjustments. Mubin was going to cover that in the next section, so I'll speed through the rest of mine and let him crack on with the interesting stuff. First, there are 3 ways that practices typically identify eligible patients. The first is doing a register search and then sending an invitation. So the ICB systems team have developed a search which is available, and Sarah will show you where. If you use that search, you can identify potentially eligible patients. You can then do ideally do a manual screen, and then send a text message or Accurex message with link to a landing page which has more information about the service, so that then only the people who are interested in the service and see that they fulfill the basic eligibility criteria get back in touch with you and say they'd like to talk about a referral. So it's a way of contacting people quickly, equitably, and then making sure that only the ones who are interested in doing this at this point in time talk to you. So it's quite an efficient way of doing things. Otherwise, you can do it through usual care. So that's either on diagnosis, you can let people know about the service, or in annual reviews, long-term condition reviews, etc., and sometimes at patient requests. And we, in the sense of Johnny particularly, can also support you with more bespoke approaches. So if you have a particular population you want to reach out to, or you're just passionate about supporting your patients in your practice and you think that they would benefit from an in-person event, then to coordinate support for that. and share lessons learned about what works well and less well in different places. So usual care is the most relevant to the patient at that time in their lives, because they're the ones, it's whether it's on diagnosis or annual review, they're most likely to be thinking about doing something. And the search and invitation is the most efficient from your point of view, because you don't have to have as many conversations with people for whom the service is less interesting. I mentioned we have a landing page, so just to show you what that looks like very quickly. It's a welcome description of the program. They can download a leaflet, more about the program, some case studies, actually mainly from Birmingham and Solihull area, the eligibility criteria, etc. So that's a brief landing page that you can send people a link to very easily in a text or AccuRx message. There's a page of case studies, which is also referenced on the landing page, as you just saw. We do have an animation that is fairly basic, but is good at raising awareness of it, and then links in turn to the landing page. So if you prefer, or as well, you can send out the animation link rather than just the landing page link. There are patient leaflets available electronically for you or for your patients, and also in print if you need them, and practice posters in a little bit more detail. Here is the patient leaflet. Sorry about the video bit at the bottom. I can't get rid of that for some reason. It's a two-sided A4 leaflet, so if you want to print it in practice, you can. And it has some key information about the service, some of the benefits, and then next steps. The poster is very simple. You can get hard copies from us potentially. Again, with easy next steps. So that is all from me for now. You'll be glad to hear, and I'll hand over to Mabine to talk to you through the medication adjustments. I'll stop sharing mine.
Hi everyone, my name is Mobeen. I'm one of the diabetes pharmacists at the BSOL ICP, and I'll just present on the medication adjustment slides for patients enrolled onto the program. I'll just do a quick screen share. Okay. So just a bit of background, I'll just put in some figures as well to give an idea of the program. So the landmark trials were the direct and the droplet trials. You can actually look at those in a bit more detail on the Momenta website for the resources for referrers. A lot of information on that I advise looking through after this presentation. And ultimately, on the first day that patients were enrolled onto the program, all blood glucose lowering agents were discontinued, as well as BP lowering agents. And what they found was with the blood glucose lowering agents, it was great. However, with the BP agents, some of them were retitrated because there was a significant drop in blood pressure. However, for the blood glucose, there was a pretty big drop, which we'll get onto a little bit later. So from the direct study, that was these figures that you'll just see here. So at 1 year, 46% of people in the intervention group achieved remission, and compared to the 4% of the control, which used other measures to help patients get into remission. Ultimately, what they found was that there was a strong association between patients that had lost more weight and them ending up in remission. So the 2-year data from the direct study showed that 64% of people were in remission that had a weight loss of 10 kilos or more. And that was at the 2-year mark, compared to 29% in remission that had just lost 5 to 10 kilos. And as you can see, 5% with a 5 kilo or less weight loss. And from the studies, from direct, the nurses or dietitian provided the behavioral support, and this can also be achieved by non-healthcare professionals that are trained in sort of dietetics background, which is what our coaches at Momenta are. They do have dietetic training, so they are very well equipped and trained to manage patients that are enrolled onto the program. So just an extract from the direct study. This is a 12-month and a 24-month mark. You can see on the left here, the red bar down here, a mean weight loss through the intervention group. So patients that had a were on the formerly known as the low-calorie diet with the soups and shakes that Harry just mentioned. We saw an average mean weight loss of 10 kilos versus 1 kilo at 12-month mark, as opposed to versus the control. And at 24-month mark, a bit of weight was put back on her, but it was still greater on the intervention group versus the control. And what impact does that have when we look at in those patients that end up in remissions? 46% patients in remission at the 12-month mark and 36% of patients at the 24-month mark. And once again, we look at the percentage achieving remission versus the patients with their weight loss. And what we found was ultimately patients that had the greater weight that was lost, the more likely they were to end up in remission. And at 10 kilo or more weight loss, that was a really good area to aim for in order to achieve for remission at the 24-month mark. So once again, this extracts that you're seeing here, these were taken from the direct study. And on the left, you can see blood glucose levels and patients that were enrolled onto the path to remission. And bearing in mind, these antidiabetic drugs were stopped on day one of starting the diet, just abrupt stoppage. It wasn't gradually titrated, which I'll touch on in a little bit. But what we can see, the reason or the rationale for it is if we look at this steep drop here, just at week 1, it's a pretty significant drop, which means we can then discontinue abruptly and then maintain. And we're seeing a bit more of a natural background blood glucose readings from these patients. And when we shift over to the blood pressure side of things, we can see a smaller drop in the systolic pressure, not as perhaps significant as the blood glucose, but still a drop meaning or indicating that we may need to adjust antihypertensive medications, which once again I will touch on afterwards. So what does that mean? It means ultimately not all medications will need to be stopped or adjusted, but some will. It depends on what medications the patients are prescribed, how many they're prescribed, and what they were prescribed for. And the information that that's been provided is all come from an expert advisory group of consultants, diabetology specialists, primary care clinicians involved in both these landmark trials. And they're designed to be safe, effective, evidence-based and pragmatic. The reason why I'm trying to reassure you guys a little bit here is because it feels a little unnatural just to stop medications abruptly. We're very used to seeing patients that are prescribed medications for chronic conditions being gradually weaned off and then initiated a new medication, or as they're being stopped, it gradually weaned off. But on this total diet replacement, it's a bit different. We'd stop the antidiabetics abruptly on day 1, even if that's a sulfonylurea. And that's once again, it's backed by the evidence base through experience through these landmark trials. So how do we go about making these changes? What do we change and when and how do we do it? So there's a couple of rules. So it depends ultimately how many medications the patients are taking. Now, bearing in mind, a part of the inclusion criteria is that the patient is diagnosed within a 6-year period. So usually you would expect to see a huge list of anti-diabetic medication in the majority of patients, normally a couple of antidiabetics, and their slowly doses are being titrated and they're being switched for alternatives. So the first rule, if a patient is taking 1 or 2 of any glucose-lowering agents, these should be stopped on the first day of the total diet replacement. So whether that be metformin, glycoside, any two anti-diabetic medication, stop completely on the first day. Now, patients taking 3 or more anti-diabetic medications, this is now where we can discontinue 2 of those anti-diabetic medications and continue the one. The one that we'd continue is one that is safe in the total diet replacement. So ideally, we're looking at metformin as one of those first-line drugs that we can continue whilst the other 2 are discontinued. Other drugs that are compatible are DPP-4 inhibitors, pioglitazone, drugs that don't cause any hypoglycemia or any risk of DKA. Those drugs are not compatible on the program, and we'll come across that in the next slide. Now, when these changes are made, there is a medications adjustment form, and on that form you specify which medication the patients are taking, even if it's perhaps an acute medication that was recently prescribed, or for the medication that may not be adjusted because it wouldn't need to be, for example, for hypertension, you would still document that medication, but the medication that would be stopped would need to be put onto the medication adjustment form as well. So you're probably familiar with a lot of these medication classes, yeah. So on the left, you've got the class of the medications, and we've got the example of the drugs. And this column here on the right-hand side, is it safe with the total diet replacement? And we've got yes and no here. Ultimately, the ones that are compatible, those patients can remain on those medications whilst on the diet if indicated. And the ones that are not compatible are the ones that are going to be increasing their risk of hypoglycemia and the effects from that. So we're looking at sulfonylureas still commonly prescribed and meglitinides, which aren't really commonly prescribed. And we also have the SGLT2 inhibitors, which are becoming very popular now due to their secondary benefits. So they're at risk of causing a DKA, so they're not compatible. So any patients that enrolled onto the program need to ensure that they are not continued or started during that program. However, the remaining of the medications, the patients may possibly remain on those where applicable. Oh, and also the reason why there's no insulin on here, if anybody's wondering, is because you wouldn't be included. It's an exclusion criteria insulin, so the patient wouldn't be allowed to be enrolled onto the program. So just going off the rules I mentioned before, if the patient's taking 1 or 2 anti-diabetic medication, you'd stop them immediately on day 1 of the total diet replacement. If it's 3 or more, 2 of those can be stopped, and 1 or 2 would need to be continued, and of that it can be metformin, any drug that's compatible. So here it's a quick what would you do scenario. So if you guys like, anyone can just comment in the comment section as to what would you do in this case. So Anja is on metformin, might be fairly common. So patients being referred only on metformin monotherapy on the total diet replacement, what would you do? Continue or stop? Okay, so in this case, we would stop the metformin. Remember, we'd always stop 1 or 2 of the medications. It's only if there's a third medication that's prescribed that one medication would need to be continued, and that would want it to be metformin. So Balgit, scenario 2, prescribed metformin, glutathione, another common combination in such case would be continue or discontinue. So yeah, we discontinue both the medications. Now in scenario 3, Claire is on metformin, empagliflozin, and liraglutide. So of these medications, as mentioned before, we go to the rule of stopping 2 of the medication and continue the metformin. So in this case, empagliflozin, liraglutide can be discontinued and the metformin continued. And once again, it's the same for scenario 4, David. The sulfonylurea and DPP4 can be discontinued. Now, DPP4 is safe as well as metformin, so you could think, could I continue the DPP4 inhibitor as opposed to the metformin? However, in terms of insulin sensitivity and the cardiometabolic effects that you get from metformin, they're a bit greater than the DPP4 inhibitor, so we prefer the DPP4 to be stopped and the metformin to be continued. And case 5, we've got 3 anti-diabetic medications and no metformin because the patient may be intolerant to it. So there's only 1 medication here that could be continued. So you guys might already picked up that medication will be DPP4 inhibitor compatible in the total diet replacement. SGLT2, T2, once again, risk of DKA and risk of hypoglycemia with sulfonylurea. So when it comes to restarting medications, as Harry's mentioned, the coaches will be in regular contact with the patients, and if blood glucose or HbA is raised at 0.6 and 12 months, then you may need to initiate a medication for that patient whilst they're on the total diet replacement. So the first line we recommend is metformin, and then after that you've got options of a DPP4 inhibitor or pioglitazone, depending on the patient's comorbidities. And just once again, we've got the red box there just to say meglitinides, sulfonylureas, and SGLT2s must not be used for the reasons mentioned earlier. And if a patient needs to be initiated on insulin for whatever reason, the program must then stop. So just going on to blood pressure medications. So with blood pressure medications, as you saw previously on the direct study, the systolic blood pressure didn't really drop significantly, but depending on the patient's current blood pressure, that small drop may then put them into a safe zone or into a zone where they're high risk of hypo. So we may need to adjust that antihypertensive accordingly. Now, the way we'd look at either reducing the dose or discontinuing an antihypertensive is looking at its indication, and also we look at when was that medication added. So as antihypertensives are added at step 1, step 2, step 3, the drug that's added more later, so if a diuretic was added at phase 3 and that was solely being used for controlling blood pressure, such as indapamide, and that would then be discontinued at that point, and the other 2 medications would be continued. But if one of the antihypertensive had a dual indication, such as bisoprolol for cardiac-related conditions as well as blood pressure, you wouldn't want to stop that because it had a secondary indication to it. So you'd want to skip that medication, move to the next medication, and then look at discontinuing that. And I'll just go over to the thresholds as to at what point do we discontinue, at what point do we reduce dose, and when do we do it? And once again, when it comes to blood pressure, it is going to be clinical judgment because you know your patients fairly well, so you'd have a better understanding of their sort of background control of the blood pressure. So you're probably familiar with the nice algorithm with antihypertensive. If you look here on this section on the right, the cutoffs for BP. So if a patient's systolic or diastolic is either above 140 or 90, then make no changes, continue on the antihypertensive, no adjustment need to be made on doses or the drugs themselves. The only time we'd make an adjustment on the dose or the drug itself is if the systolic is less than 140 and the diastolic is less than 90. So if both are less than those thresholds, then we'd want to make an adjustment. Now that adjustment is going to depend on sort of the clinical scenario or clinical picture of the patient. You may need to half a dose, you may need to discontinue medication completely. And once again, the patient's BP will be getting monitored. And that change of that dose adjustment or discontinuation is done on the day the diet starts. It's not done before, it's not done after, it's done on the actual day. The same with the blood glucose lowering agents. Now, there may be a slight impact of a total diet replacement. It's going to have, it might have a slight impact on patients' current regime, depending on what medications they're taking. So you're probably already with warfarin, obviously with encouraging a healthy sort of diet now. So it may involve more leafy greens. So that may affect the patient's INR. And as a result, it may mean a dose adjustment. Same as some of the NOACs, which are based, sometimes some of them based to the doxamine on body weight. So if a patient's near the 60 kilo threshold and they've lost a few kilos and now they're less than that, the dose may need to be adjusted. And we have certain drugs that are protein bound, and this may have an effect. Certain drugs that have a narrow therapeutic index, so we just need to be a little bit mindful of these drugs. Your pharmacist working in the practice, your PCM pharmacist or your ICB pharmacist, I'll be more than happy to help out if you need any support in making such adjustments. So when it comes to the monitoring side, there's a lot of emphasis on this element, and want to prevent any harm where possible. So that's why, once again, any significant raised blood glucose levels or significantly high or low blood pressure will be fed back to the GP, as Harry's mentioned earlier, and an action will be taken accordingly. So on the medication adjustment form, that would obviously need to be completed with the adjustment, but there are some common issues with the form. You'll have a look very shortly. One is patient not receiving a copy of that form, because when the patient comes to meeting their coach, when being enrolled onto the total diet replacement, they would need a copy of the form so they know what medications have been stopped or adjusted. Another factor is where no medication require adjusting, they also must be entered into the MAF form. So a drug may not be related to the cardiovascular element, it may not be related to diabetes or blood pressure, but we still need to document it for record's sake. And any acute medications that perhaps may not have a primary effect on hypertension could later on have an effect. For example, tamsulosin for BPH, it may slightly have an impact on BP, so we advise or encourage all medication to be put onto the MAF form. So just some final points. Let's ensure the patients are taking the medication, and the acute medication and the variables are all put onto the MAF form. And just ask yourself when making such referrals, if someone had lost a significant amount of weight or had a major dietary change, what dose or what drug may need to be adjusted. And if once again, if you're in doubt, just ask one of your pharmacy colleague. Okay, and we just need to make sure that referrals that are being made safely. So there is a lot of guidance on the Momenta website for the resources for referrals. I definitely advise looking back on that. You can find this presentation on there. You'll find recordings of presentation. You'll find a lot more detailed information on medication adjustments on there as well. So that's just my bit over. And just before I hand over back to Harry, I'd just like to say it's quite rare that we find a chronic condition that can actually be reversed and medications be discontinued like this. So it's a great opportunity. It's a free service, and I'd highly recommend encouraging referrals into the program. Thank you.
Perfect. Thank you very much, Mubin. And although it's my screen share, I'm actually going to be PowerPoint Sarah. So over to you, Sarah, to talk about the referral support.
Thank you. Yeah, so this first slide is just going through how to make a successful referral. Harry did touch on this earlier, so I won't go through it. It's just in terms of how to identify through a search or through their usual care. And then the referral appointment, just making sure you are discussing those medication changes and including that in the MAF, even if it's just a tick box to say that there's nothing to be adjusted. Otherwise, the referral will be returned. Sorry. Yeah, and just to make sure you provide the patient with a copy of that. And then, yeah, just to check all the sections on the referral form are completed in terms of the date of diagnosis, the age of the patient, especially, and the HbA1c. Yeah, so in terms of the searches, it's slightly different for EMIS practices and the System 1 TPP practices. So the EMIS practice guidance, you will get these slides, so you'll be able to see the screenshots. But if you're going from the central reporting units for Cross City or South Central, it'll be the top screenshot where you can find your eligible patients. And in terms of searches for those that used to be part of Sandwell CCG, it will be the bottom screenshot just to find the search and reports for your eligible patients. In terms of the System 1 practices, they have all been updated onto the NHS Birmingham Solihull CCG, which can be located under the Type 2DR programme. And the same as the low-calorie diet searches, there are two sets of searches that you can use. The Step 1 identifies all eligible patients, and there is a newer search that identifies eligible patients with some further drug exclusions, which makes it easier for practices. Yeah, in terms of the referral form and the medication adjustment form. So for EMIS practices, the referral forms have been rolled out to all practices, and your CSS will have advised where these can be located. But if you are having trouble at all, just let me know. You can just search T2DR in your EMIS system, and it will display both the referral forms for EMIS and show where they can be located. And for TPP System 1 practices, they are located in the CCG letter templates folder under referral forms for diabetes. So you have got both the referral form and the invitation letter saved in there. And again, you can search T2DR within System 1 as well if you can't locate them. But please let me know if you've got any issues. Yeah, so you just need to complete the referral and the medication adjustment form, which is all included in the same referral form, and send to Momenta. And as I said, if you've got any problems accessing any of the forms, please contact your local CSS or myself in the first instance. Short and sharp.
Perfect. Thank you so much, Sarah. I'm just going to give you a quick whistle-stop tour, conscious of the time, of the referral form so you can see what's involved. However, there's a small little but to this. At the moment, the forms that you have, that you can access will be changing over the next month or so. So rather than going through the current form, which is slightly simpler than the version I'm going to show you, I'm going to go through the form that you will have, because that will be of more use to most of you. The existing form is similar, but has slightly less on it. So it will be very much the same, but just not quite as complicated, or not complicated. That's the wrong word. As involved. So the new version of the form has been developed following some discussion with other ICBs where we've been setting up the service and taking on board some of their thoughts, as well as previously the ones that we just had from BSOL. So this is the Word version, not the version on EMIS or System 1. It will have initially some clarity over the actions required by you as a referring practitioner. So it just gives a brief overview of the program here, and then it talks through the different actions and what's required. So it's a recap of what we've discussed. There's then the declaration. So it just covers off some aspects that make sure it's like a checklist, if you like, to make sure you've discussed those things with the patient. And all these grey fields here auto-populate from the system. Every now and again, there's a free text version like this, and the free text is put in. So, for example, I saw a comment in a question in a chat. If you are making the referral, but you're not the person who is either who is signing off the medication adjustments, then it will pull through your current details as a current user. but you can put in the name of the person who's signed off the medication adjustments. That's helpful for both yourself, but also if there are any subsequent threshold breaches or anything, communications from us, then you'll have a record on that patient's record on the referral form as to who it was who signed off the changes, and therefore who might be the best person to talk to about any subsequent changes. There's then information, there's some information about information sharing. And then this is the kind of key main elements of the referral form, which again, largely auto-populate. And these are the same on the current form as on this version. It's just we've added in a few highlights to check some things. So going back to the eligibility criteria that were circled, these are the key things to check, where sometimes we get ineligible referrals sent to us, and that's not a good use of your time or patients. But the rest of this will all pull through, apart from some of the information about checkboxes down here. This information all pulled through from the clinical system, apart from the bottom 3 rows, which are manual entry. Then we have some information that is for your reference. So we've got the inclusion and exclusion criteria that are here. So you don't have to go somewhere else to double check. And this section here expands and it pulls through current and acute medications. Again, it's for your reference, so you don't have to keep on going back into the patient record to when you're looking at doing any medication adjustments. So you've got both the eligibility criteria to double check as reference information and the patient's medications that will pull. Then there's some text about what you need to do on the medication adjustment form. So you've got to fill out section A for everyone, whether they're on any medications that need adjusting or not, and section B only for those who need any adjustments. We've also done in this version, which you'll get in the next month, as I say, but not in the current version, is put in a flowchart. Again, not as an exhaustive section on the medication adjustment changes that Mabeen's talked you through, but as a quick reminder. So a first section on the blood glucose lowering agents. It's basically just a flowchart summarizing what Mabeen was talking through. Then a section on the blood pressure lowering agents, and then a section on the other medications, along with the key reminders and about completing a referral form, and also as a reminder or refresher about what we will monitor and notify you about. And this final section is the medication adjustment set form itself. So this top section A needs to be completed for everyone, please. And so that is that's fairly self-explanatory. And if these are all no's, then the top ones, then that's it. But if there are medications that need adjusting, then this is where you can do it. Either as free text in this first row here, or in the individual rows, you can pull from a drop-down. It looks like NA here, but when it's on a system, it's a drop-down, which has the medication name in it, so you don't have to write it in, and then the action of whether to stop or reduce. And if it's reduced, then you can write in what it is they have to reduce it to. There are a few notes for you at the bottom, including a reminder to give the patient a copy of it and a link to the QR code and the SNOMED code. Right, so that is, you'll be glad to know, the medication adjustment form, or referral and medication adjustment form. There's some information about payment for practices here. Basically, you're eligible for £11.50 weight management enhanced service fee for eligible referrals, and there's information about how to code it here. Then there's also some top tips for both the searches and the referral form. Because you get these slides, we won't go into these at the moment. But fundamentally, the key points are to just confirm the eligibility criteria before you go through the full appointment with the patient. Otherwise, it takes up, as I said, their time and yours, and then in fact ours as well, because we have to return it to you or just tell you it's not eligible. Searches, if you do go down the route of using searches, which we would definitely recommend you consider, because it makes life much more efficient for you, then just a reminder to do the manual screen beforehand to just confirm that you're not sending lots of people information about the service that it's not relevant to. And if your list is very long, then you can look at it in chunks or to kind of triage it. This next slide is basically a one-page service overview. So if you want to print this off or keep this, you can do that. I won't go through it in detail because it's just summarizes what we've talked about. But it's got helpful links at the top. It's got the search and invitation route in with the relevant SNOMED codes. It's got usual care route in, the referral process or appointment, what to do, and then what we do at different points of the service, what we do on discharge, and where you need to do the repeat HbA1cs we've talked about, and the fact that if the referral is incomplete, then we'll come back to you requesting any further missing information, and during the service we will notify you about threshold breaches. Right, you'll be delighted to know that's it from me. I will now hand you over to Johnny to discuss contacts and next steps.
Cool, thank you for that, Harry. So yeah, as you mentioned, I'm going to take over the next couple of slides and we'll go over some key contacts, next steps, and a little bit about our referral numbers to date. I'm a little bit conscious of time, so I'll keep it pretty snappy. So for those of you who are not familiar with myself, my name is Johnny and I'm the engagement lead for the area. And what I'll do right now, I'll place my email address in the chat in case you think of any questions after this presentation or require any help with regards to the programme. So if you just bear with me 1 second, I'll share my contact details.
While Johnny's doing that, you can also, when you get the slides, you can just click on any of these names and it will send an email to them.
And what I will also share in the chat is my booking link. So if you require any further support, please feel free to click on that link and it'll give you about a 45-minute slot with me where we can discuss the referral process and the programme in more detail. And yes, Harry, that's an excellent point, actually. The email addresses are embedded into that slide as well. So yeah, so the next steps, so following on from this presentation, you will receive an email which contains the slides from today, a link to the presentation which is being recorded, and other resources such as the NHS guidance on medication adjustments. And as Harry mentioned before, of course, we are happy to attend any meetings, events, or anything else you feel that is relevant for us within the T2DR space. And before we wrap up, I would like to just say thank you. Thank you to all the primary care staff who've helped raise the profile of T2DR within their practice. And ever since we began the new contract as of June 2023, we have surpassed our monthly referral targets and are on course to do that again this month. And we, of course, couldn't do that without you. Throughout the new contract, we've received 471 referrals, of which 85 were deemed ineligible, which is about 18%. Our target is to have 15% or less in terms of ineligible referrals, so we do need to have a little bit of work, but hopefully sessions like today will help improve that. And of course, if you have any questions, please feel free to reach out to myself or anyone else who's helped present today. And lastly, if you feel your practice has space for an in-person clinic, please let me know and please drop me a line via my email address. We currently have programmes at the Windmill Community Centre and Handsworth, the Stetford Leisure Centre and Foxhollies Leisure Centre, just to name a few. So thank you for your time, everyone. We'll happily take any questions.
We just can't provide you with a virtual lunch, unfortunately.
Has anyone got any questions for anybody before we close?
Do feel free to shout them out rather than put them in the chat if that's a bit faster. Much appreciated. Referrals are always welcome. Thank you very much.
I think I'll stop the recording there.
Perfect. And thank you all for your time.